Hello, Overcomers, and welcome to this episode of Connect Ovar Coffee. I'm Rinsi, the founder of Ovarcom, and today we are joined by a very special guest, Dr. Liz Swisher. So, Dr. Swisher is professor and director of the Gynecologic Oncology Program at Fred Hutch and deputy director of the Fred Hutch, EUW, and Seattle Children's Cancer Consortium. She is the principal investigator on several PARP inhibitor therapeutic trials and leads the translational research for numerous other clinical trials as well. One of nation's top doctors, Dr. Swisher, is passionate about patient-centric care and outcomes. So we have a lot to chat with Dr. Swisher today, focusing on the latest advances in ovarian cancers and also learning from all the groundbreaking work that she's doing to advance the science in ovarian cancer. So grab your favorite beverage. I have mine, and join us for the next 45 minutes or to an hour as we chat with Dr. Swisher. And as I always say, if you have any questions as we go along, please type in the comment sections below, and we will get it addressed post the discussion. So with that, a huge honor for us to welcome you to this episode of Connect Ovar Coffee, Dr. Swisher.
Thank you so much for having me. It's an honor to be here.
Thank you, Dr. Swisher. So I have several questions, but before we get into the details, in understanding the basic biology and the interdependencies, right? Can you tell us a little bit about the ovarian, endometrial, and uterine cancers and their similarities and differences, as well as the risks of one type of cancer translating into a secondary development for the other?
Okay, so endometrial cancer and uterine cancer are words that are often used interchangeably. The endometrium is the lining of the uterus and is the most common site for uterine cancers. You can get cancers of the uterus in the wall of the uterus. We usually call those sarcomas. But the sort of common endometrial cancer and uterine cancer are the same thing. Ovarian cancer is a little bit different in that ovarian cancer is really a mix of different cancer types. Many of the common ovarian cancers actually arise in the fallopian tube. Other types of ovarian cancer do arise in the ovary or in endometriosis. So that some of the commonalities between endometrial cancer and ovarian cancer kind of are certain subtypes have particular commonalities. There is an endometrioid type ovarian cancer, and that's an ovarian cancer that looks a lot like endometrial cancer under the microscope. It arises in endometriosis. Endometriosis is a benign disease that probably comes from endometrial cells that are shed out maybe during menstruation that go retrograde through the fallopian tube and get shed out into the onto the surface of the ovary or other places in the pelvis. And then most of the time is benign, but once in a while can undergo malignant transformation. And then that becomes a cancer that's we call endometrioid ovarian cancer. Endometriosis can also give rise to clear cell ovarian cancer. That is a rare type of ovarian cancer that is less responsive to chemotherapy than many of our ovarian cancers. So the commonality between endometrial cancer and ovarian cancer tends to be from those specific subtypes that probably also arise from endometrial tissue originally. So in some ways, they may be more like endometrial cancer than they are like the most common high-grade serous ovarian cancer. Yeah. And so high-grade serous ovarian cancer has a different pathway of development and therefore different sensitivities to treatment. Endometrial cancer is more hormonally driven, has also different genes that are involved in different pathways, and that may be more similar to clear cell and endometrioid ovarian cancer. So we're starting to learn really to personalize therapy, not treat all ovarian cancers the same. And we used to have like clinical trials that would enroll all women with certain stage ovarian cancer, and they all got the same treatment. And now it's really only recently where we're starting to say, okay, let's have a trial just for clear cell ovarian cancer, because it doesn't make sense to be treating them like one cancer type. They're not even coming from the same original tissue. They have different pathways of development. So we get insight, I think, from endometrial cancer to some types of ovarian cancer and vice versa. in terms of risk of cancer, which was kind of the second part of your question, ovarian cancer, I mean, the ovary itself is a very receptive place for metastasis. So endometrial cancer can metastasize to the ovary, meaning it started in the endometrium, but then it spreads to the ovary, and then you really treat it like where the cancer started, not where it ends up. That's what's most important in terms of what its sensitivities will be. But other cancers, even like breast cancer, et cetera, can go to the ovary. The ovary tends to be sort of maybe a kind of a favorable environment for cancers to like land and then grow. But if you've had one cancer type, it doesn't necessarily mean you're at higher risk for the other cancer type, except just for some common risk factors like not having had children, for instance, is a kind of a risk factor for breast cancer, for endometrial cancer, and also for ovarian cancer. But it doesn't mean that if you haven't had kids and you've had ovarian cancer, that you're high risk for endometrial cancer. I mean, most people who have ovarian cancer have had a hysterectomy, so really they've eliminated their endometrial cancer risk. The same is true for people with endometrial cancer. They've usually had a hysterectomy and they've eliminated that risk. There are a couple like genetic things that would put you at higher risk for both. So one is Lynch syndrome, which is an inherited genetic predisposition to colon cancer, to ovarian cancer, to endometrial cancer, endometrial and colon cancer being the most common cancers. So sometimes there's some overlapping risk, but for the most part, they're sort of, two separate things that are not one going to put you at super high risk for the other.
Wonderful. Thank you so much for the clarification. And so your research interests include clinical trials, right? Focusing on new therapies for ovarian, uterine, and cervical cancers. So can you tell us about the clinical trials in ovarian and uterine cancers that you're working on and are most excited about?
Yeah, so there are so many things happening right now in cancer therapy. It's a really exciting time. And I think it all boils down to this, what we call precision medicine or precision therapy, where we're not treating all the cancers the same way. We're looking for specific vulnerabilities in each individual cancer. So that's why if you've had cancer, you might have had tumor sequencing done, where they're looking for changes in certain genes that are occurring in the cancer, because that gives us an idea of what's driving that cancer. If we know what's driving that cancer, we know what it's dependent on. And there may be therapies that take advantage of that dependency the cancer has. The more that we take advantage of a dependency the cancer has, the more we can direct a therapy that will be effective and potentially less toxic, because we're targeting what the cancer is susceptible to and not just, targeting all the cells in your body. So there's so many developments now that it's hard to describe them all in a short setting, because there's all these different potential pathways available, and all these drugs are being looked at in kind of subsets of cancers. So they may be instead of doing testing a drug in all patients with ovarian cancer, they may be testing that drug in just patients with ovarian cancer that have a specific mutation, like, for example, a mutation in the ARID1A gene, which might only be 3% of ovarian cancers. But that, and so there are kind of trials that are very oriented towards a small subset of cancers, because that drug has, that's what it's been developed for, or that's where it's been shown to be effective. So I think that's happening in both uterine and endometrial cancers. One of the really key areas in ovarian cancer is are the antibody drug conjugates. So an antibody drug conjugate is where they take an antibody. An antibody is a protein, kind of like what your body makes to fight infection, that's specific towards one thing. So your body might make an antibody towards the virus, but here they've constructed an antibody that's identifying something on a cancer cell. So your cancer might express something, say, folate receptor. And if that's on the surface of the cancer cell, the antibody is going to kind of latch on to that. And then attached to that antibody is a little bit of chemotherapy. So that we call that the payload. So the antibody is conjugated to to a drug. That's why they call it an antibody drug conjugate. The drug is the chemotherapy. So it's still kind of working like chemotherapy, but what it's doing is the antibodies, like the nuclear warhead, it's honing in, it's heading towards the cancer, and then once it gets there, it gets internalized potentially into the cell, and then that little chemotherapy packet or several packets are attached to the antibody is released. And it can kill that cancer cell more specifically than just putting loose chemotherapy that has to go everywhere and it's going to get to all your normal cells. So some of that chemotherapy is absorbed into your system. So there's still toxicity related to the chemotherapy, but the ratio of how much the cancer sees and how much your healthy tissue sees has been changed by that design. So there's just hundreds of antibody drug conjugates being, out there in clinical trials right now. They're being designed for different cancer types. They're being conjugated to different types of chemotherapy, and they have different targets. So that's really there was one approved in ovarian cancer, and there's a whole nother series, I think, on the horizon. And so we're pretty excited about that development. In endometrial, and one of the things that's kind of lacking in ovarian cancer is really effective immunotherapy. So one of the developments in uterine cancer has been to utilize immunotherapy in combination, often with chemotherapy, to make chemotherapy more effective in patients who have just been diagnosed and have high risk cancer for coming back, or they're going to get chemotherapy to try to make sure the cancer doesn't come back. It's more effective than to add immunotherapy to that. In the patient who has unfortunately had a recurrence, immunotherapy can be really effective in endometrial cancer. So that now has really become standard of care in endometrial cancer kind of across the board. In ovarian cancer, those same drugs have been less effective. So we're still in ovarian cancer figuring out how can we make immunotherapy more effective. Immunotherapy has changed cancer treatment radically over the last 5 or 10 years in many different cancer types. Lung cancer used to be, when somebody got a lung cancer diagnosis, you knew they weren't going to be around in a couple of years. And now people are saved and cured from lung cancer. And that really is because of immunotherapy. It's changed really the field for many cancer types, but not so much for ovarian cancer. So that doesn't mean the immune system isn't important in ovarian cancer. It means we haven't figured out how to harness it most effectively. So there's really, I think, still, people haven't given up on that. There's still a lot of excitement and new ways of potentially harnessing the immune system, which I think is going to change, is going to kind of bring those advantages to treatment of ovarian cancer. So the antibody drug conjugates and immunotherapy, I'd say, are the two big areas of development.
Thank you. And before I move on to my next question, I want to say that I have heard the best description of the ADCs from you in recent times. So thank you for that beautiful breakdown. So we were talking about progress and the advances that you think would be happening in the next couple of years. So what does progress look like for you in ovarian cancer in the next couple of years?
So progress to me is that we treat each cancer like a puzzle. Each cancer like an individual puzzle, and we know the best way to treat that cancer by having profiled it with all of our molecular tools so that we can basically take somebody who has been newly diagnosed with cancer. We do a whole bunch of tests that tell us, okay, these are the vulnerabilities for this cancer, and then we pick a drug or a cocktail of drugs that are going to be super effective for that cancer. So that's that could just be sort of profiling. It could be taking biopsies and testing it against drugs. There's this whole area called functional precision medicine. So precision medicine is when we treat each cancer individually according to what it's most vulnerable to. Functional precision medicine means we're taking that tumor and we're profiling it in a way that we know how to treat it and doing sort of tests. So artificial intelligence is going to be, I think, harnessed to help us do precision medicine more effectively.
Yes.
So we are accumulating like vast amount of data on tumors, and every tumor is different, right? So how do we connect knowing which, how to treat each tumor? So artificial intelligence is going to be layered in there to help us more precisely treat each cancer in the most effective way from the beginning, not waiting until you recur or what have you, and then having to get secondary treatments. So we're really at, like, I think, a very crucial time in cancer research to take what we've learned about profiling cancers and now really effectively change therapy for individual patients.
That's wonderful and very hopeful. Thank you. And so, in understanding more about the types of secondary cancers that may develop as a complication of therapy, right? So, what is the percentage of such incidents that we would? Is there a particular patients that are more susceptible versus the others in developing these secondary cancers? And in terms of that, what communication is conveyed to the overcomers in understanding the risk of developing secondary cancers as a result of treatment from the primary?
Yeah, so the first thing we need to do is cure everybody from their cancer. So that is the most important thing. And people who've had one cancer are at higher risk for having another cancer type. But if we don't cure the first cancer, people don't live long enough to, have another cancer. So I think that the problem of having a second cancer, I wouldn't say it's a good problem, but it's the longer that the more effectively we treat people and the more survivors we create, the more we have to be concerned about what survivorship looks like and not wanting people to get another cancer down the road, especially one that is potentially avoidable. So some of those cancers are random cancers, like, your risk of cancer goes up when you're aging, but there are cancers specifically related to the therapy that you got. So platinum chemotherapy, which most patients with ovarian cancer will get, is particularly associated with risk of secondary blood cancers. So that's like a lymphoma or leukemia, or what we call myeloid dysplastic syndrome. So those are cancers of the bone marrow that then circulate in the blood, which is caused by the toxic part of the chemotherapy having caused some damage to stem cells in the bone marrow or the blood. And years later, so it doesn't happen while you're getting treatment, then years later. So what are the risk factors? The risk factors for that are the amount of chemotherapy that you've had, particularly the types of chemotherapy that are associated with those kind of secondary cancers. So platinum being like a big one. Other kinds of chemotherapy also can cause it, but with ovarian cancer patients, often they will get, they might get one regimen of platinum-based chemotherapy, and then maybe a couple of years later, they have another bout with their ovarian cancer and they have to get that treatment again. And so it's cumulative. The more kind of toxicity, if the toxicity accumulates of that secondary blood cancer, the more exposure you have. So PARP inhibitors are also known to cause this. And so the combination of platinum and PARP inhibitors, which is very effective for ovarian cancer, also increases the risk. So your risk of getting one of those kinds of cancers is, if you're a patient with ovarian cancer, if you've just had one course of treatment, and it's only about 1% to 2%. But if you've had, say you've had 2 courses of platinum chemotherapy, not 2 cycles, but 2 different, 6 cycles here and 6 cycles there, 2 different times, plus you've been on PARP inhibitor for 2 years, then your risk is as high as 10%. So that's a pretty high risk. But of course, if this is a curative therapy, we want to give that therapy because we don't want someone to die of ovarian cancer. Yeah. On the other hand, if we're going to cure them of ovarian cancer, we want to know that we're not going to give them like another cancer that may be life-threatening down the road. So we're really interested in looking at that and understanding what what is happening in the blood when we're treating patients with chemotherapy that might set them up to that secondary blood cancer.
So you mentioned something about the time frame. I'm going to go back to that for a second. You mentioned that it does not happen immediately as you are going through treatment, right? So in your experience, what have you seen the typical window of the secondary cancers developing? Is it
Yeah,
3 to 5 years?
yeah. So it's often like 2 to 6 years after initial treatment. It's sort of when we see it happen more often, more quickly, it's often somebody who's had chemotherapy for a previous cancer. Like say
Okay.
somebody survived a breast cancer, maybe 10, 15 years ago, they had chemotherapy for that. And now they get chemotherapy for their ovarian cancer. Sometimes that now has already accumulated
Right.
sometimes. So maybe they were sort of in a vulnerable position when we gave them their chemotherapy. The problem being is because it affects the bone marrow, it makes your blood counts go down really low. So if you need treatment for ovarian cancer and you have one of these blood cancers, it makes it very, very difficult to give you any kind of chemotherapy because your blood counts are so low, you won't tolerate more chemotherapy. So it's a very, yeah, it's a very serious problem. If you don't have ovarian cancer because you're cured of the ovarian cancer, the blood cancer itself can be life-threatening. If you have both at the same time, it makes it hard to manage both of those cancers. So it's it's kind of it's just something that we haven't really paid a lot of attention to in the past because we were so worried. We just didn't have enough people who were long-term survivors for it to be the biggest issue. Now our patients are living longer, and we need to pay attention to it. Another reason we haven't paid so much attention to it is that oncologists that treat blood cancers and that treat solid tumors are really in very different worlds. And we don't talk to each other a lot. We have different meetings that we go to, and they're very different specialties. And so, like, there just hasn't been a lot of crosstalk between the specialties that are seeing that are treating the patients for one type of cancer versus the other. So, because ovarian cancer patients are given so much platinum chemotherapy, and they of all the solid tumors, they tend to have one of the higher risks of this type of secondary blood cancer. So we call it a therapy-related malignancy. So that means that ovarian cancer patients are really good ones to try to understand how we can better predict who's at risk and how we can potentially modify treatments to change that risk. And so we're doing a big study trying to look at that, which is, we call it the chances study.
Yeah, I was just going to ask you about that.
Yeah.
Tell us about the clinical trial that you're running, and because this seems to be, filling that gap, because this is a huge issue and challenge for ovarian cancer patients who have been treated for, as you said, long-term survivors. So tell us about the clinical trial, and then what should our overcomers know about it? How should they sign up? And anything else that you may want to share.
Yeah, so we call it chances, which stands, I hope I get this right. I'm not looking at my notes. Oh yeah, actually I do have a card with me. I have a little business card here. So it's called chances, which stands for clonal hematopoiesis in cancer survivors. And clonal hematopoiesis is basically a kind of a clonal change and expansion of cells in the blood that is not malignant. And it's normal. It's a normal part of aging. Many people have it, but it also can be a precursor to a blood cancer, but most are not. And so what we're trying to understand is that process of like being able to look in the blood at all these different clonal events that are happening and figure out which are the important ones that put somebody at risk for developing a blood cancer. So what we're doing is we're taking patients who've been treated for ovarian cancer, they can be in remission, or they can be on active current treatment. And we get a blood sample every 6 months for 3 years. And we just basically follow the clonal events that are happening, and we relate it to what they're being treated with. So a patient may sign up who's in remission, and we get a baseline blood test in 6 months. Maybe they're on some kind of treatment. Each time we get a blood sample, they kind of log in and tell us if they're on any treatment. It's that part isn't like a lot of data gathering, but we're getting data from the people in the study. They're telling us if they're on treatment or not on treatment, and we're then relating what we see in the blood to what their exposures are, which will give us a lot more information going forward, because nothing like this has been done before. It's not going to help those people directly. It's really to contribute to this bigger problem. So ultimately, it's going to help everybody, but it's not like results that some studies you're getting results back from the study as you're in the study. This is one where we're gathering data, and ultimately we're going to share that data with everybody, but it's not that individual people in the study will get individual results back. So we're pretty excited about this study. It's funded by the National Cancer Institute. And we're enrolling, and people can basically go online. There's a QR code and a website, and you could just go online. You can get information about the study. It has our contact information if you have questions. You can basically enroll purely electronically. You can be anywhere in the country. We send out a blood kit, and when you're having your blood drawn for like other reasons, or you can make a special appointment to have your blood drawn for it, and then they ship the blood to us. So you don't have to come to us. We would love to have people from all over. We'd like to get people who represent every state in the country. So the people that are not eligible are for people who had just one regimen of chemotherapy and never anything else. So if you've had a PARP inhibitor, you're eligible. But if you've only had like one regimen of chemo and you never got a PARP inhibitor, we want people, the reason being is we want people with a certain amount of exposure to sort of like have a little bit more risk of this kind of cancer. If you're not eligible for this study, it's a good thing. It means like, if we're not interested in you, it means you're too low risk for it. But if you've got a recurrent ovarian cancer, or you've had any amount of a PARP inhibitor, we'd love to enroll you. If you've been through chemotherapy and that's all you've had, but you kind of struggled with your blood counts, like your blood counts are always low, or you even had to go to see a hematologist to see if there was any issues. Those people, we'd really, really like to get them in the study, because we think that may be higher risk for this happening, and we kind of really want to understand those blood samples. So we really encourage anybody that's had any of those, we call it cytopenia, low blood counts. Everybody has some low blood counts during chemotherapy, but if it was really a problem and it caused delays in your chemotherapy, then we would love to get you in our study.
Let me ask you a clarification question on this. You said all ovarian cancer patients, but we know that, again, ovarian cancer can be different types and different subtypes, right? So for patients who have not been exposed to chemotherapy, but have been on hormonal therapies instead, are those patients eligible, or?
No, we're really just looking at this in relationship to chemotherapy exposure. Okay. So so people have to have had really like chemotherapy before, and it's fine if you're on chemotherapy at the time. We do want people who have a life expectancy of 6 months or more, so that we don't want it to be people's like final gift to us to enroll on this trial if they're at the end of life, because we want to be able to follow people over time. Sure. We appreciate the sentiment, but we want to follow you over time. So every 6 months is we know that's an ask. On the other hand, most people are getting labs done. to follow their cancer. So we're hoping to make it convenient and let people get their labs done while, get their research blood done while they're getting their labs done. So yeah, we're very, very excited about this study, and I think we're already starting to learn some interesting things. So we would really love the overcomers to be a part of that.
100%. And in terms of the recruitment, how many spots do you have? Because the reason I ask this question is oftentimes, we receive questions from our overcomers saying that we were interested in X trial, but they had only 12 spots. And so by the time I reached out, it's already full. So
Yeah, so this is one where I promise you, we will turn no overcomers away. We could enroll up to 2,000 people, which I think is a very unlikely
that's
that
a
we'll
lot.
get that
Yeah.
many. Yeah, and so we have less than 100 now, probably around 70 or so. We definitely like to get to 300 or so. That'd be so if yeah, we appreciate each and every person who wants to participate in this trial.
And absolutely, we'll be sharing all the links and all the details regarding this particular trial, because, as you said, it's something that sounds like a very innovative and new trial that you would get some good information on, and it can be a contribution to the whole community. So
Exactly.
we'll be sure to share that information. Thank you. And so. In terms of therapies with rare ovarian cancers, seems like many promising things are in motion for the low-grade serous ovarian cancers, but when it comes to the other types, what is it that you would like to share that's on the horizon that our overcomers should be aware of?
So I think that endometrioid and clear cell, I kind of referred to it before, is a little bit more like endometrial cancer or even like breast cancer. They're more hormonally driven, and some of the cancers that have been really effective in hormonally driven breast cancers are now coming to endometrial cancer, and I think will come to these ovarian cancer subsets. So that are things like targeted drugs that target certain pathways that are common between these cancers, and things like CDK inhibitors like palbociclib, abemaciclib. These are drugs that are approved in breast cancer, and I think are coming to this kind of subset of cancers. We are opening a trial for granulosa cell tumors. So granulosa cell tumor is another rare ovarian cancer subtype that's been really understudied. And we had a trial open maybe 6 months ago or so. That was an NRG trial. We enrolled like 10 patients. These patients don't have access to many clinical trials, and we haven't advanced their therapy forever. And now people are just starting to think about rare tumor types and vulnerabilities. So we have a trial that's just opening right now that I'm pretty excited about for granulosa cell tumor. So it's like really the time is right for rare cancer types, because people have stopped thinking about it. Used to be that the pharmaceutical companies only wanted to develop a drug for lung cancer or breast cancer, colon cancer, or prostate cancer, because those were the four most common cancer types. And it all had to do with where the money was. So for 2 decades, there was no therapy that was FDA approved, a new therapy that was FDA approved in ovarian cancer until the PARP inhibitors came along. And it kind of really opened everybody's eyes to if you have a very effective targeted therapy, even though it might be a smaller market, if it's really effective, it will everybody will use it in that market. And that's really that's the pathway to drug development now. So that's provided rare tumors are not on their own anymore. Now that if you're going to treat, say, a subset of breast cancer that has only this molecular alteration, then even that type of breast cancer can be a rare subtype. So now no longer is low-grade serous ovarian cancer have to be such a an outcast because rare cancer types are being like addressed in this whole pharmacy development. So I think it's a really great time for thinking about how to treat each and every one of these cancer types because they've been far too long understudied and not had clinical trials. And I think that's changing now. And I'm really excited to see what comes out of it.
That's wonderful. And so for the clinical trials that are opening up for the granulosa cell tumors, I'm assuming people can search and see what's happening in Swisher Lab, and they can figure out what the open trials are, right?
Yeah, they're always welcome to reach out to me. Clinicaltrials.gov is where all the trials across the whole country are listed. But it can be hard for people to know how to search that. If somebody, people can always reach out to me if they want directions for a trial to look at.
And we actually have a clinical trials website on our website where we have filtered everything only on ovarian cancer. So that people don't have to go to clinicaltrials.gov. If they just go to the Overcome clinical trials portal, they can search by investigator, they can search by just ovarian cancer types, subtypes. So that's a lot easier. And we also have a Spanish version for that. So
that's fantastic.
yes, it is very easy, and we also have an assistant to help them. So it's very user friendly. So you have so much wealth of knowledge, and that it's kind of hard to pinpoint what to ask you. But you also have your interest in studying the genetics for gynecologic cancers and using that knowledge to assess risk, and as you were talking about, the personalized prevention strategies. So tell us more about your interest in genetics, and what have you learned over all these years or the new things that are happening that you want to share with us.
Well, first of all, when I started, this is the thing about being around for a long time, is that you sort of realize what you've learned. Research is very much about delayed gratification. It feels like it takes a long time. But when you're able to look back and see where we came from, you sort of realize that really is how you make changes, is you push the field forward through research. So when we started, it was thought that that 5% of ovarian cancer was hereditary. So that means 95%, we didn't really know what caused it. And 5% we thought it came about because of a hereditary predisposition, a familial, link. And now we realize that it's really more like 15%, even somewhere between 15 and 20% is hereditary. And that massively changes the opportunity for people who have genetic risk to understand their risk and before they get cancer. Most of the genetic testing in this country for hereditary cancer risk is done after cancer diagnosis. Yeah. And to me, that is like, we've already, it's of course we want to do it if that's the timing, but we've lost that opportunity to prevent that cancer if we're not finding out that risk until after a cancer has been diagnosed. So, I've done a lot of studies where we're looking at how do we get genetic testing for cancer risk into the mainstream, into primary care practices, and really ultimately the testing is getting cheaper and cheaper, and we could really do it on a population level. Like you get your cholesterol screened, right. At one point at age 25 or something, everybody should be tested for all the hereditary cancer genes, and then you would personalize cancer prevention. So maybe this person gets a colonoscopy at this age, and this person gets a colonoscopy not till 15 years later. This person, you have kind of a risk profile. So this person is at higher risk for breast cancer. This person is at average risk for breast cancer. And you would personalize surveillance. You wouldn't say everybody gets their mammogram at X age, right? You would basically personalize that. So in the same way that we're personalizing therapy for cancer, we can personalize prevention. We can look at people's genetic profile and kind of figure out a personalized plan for everybody. And I think again, this is based on huge amounts of data. So I do think artificial intelligence will help us push this forward faster to understand which groups of people like should have like different kind of strategies. But ultimately, you know, like our healthcare system is so broken. You know, we can't even do vaccines. Then, you know, can we do you know, are we really going to be able to do this effectively? But all we can do basically, I think, is not necessarily, I can't fix our healthcare system, but I can provide the knowledge that hopefully will prevent cancers in the future. And so, you know, everybody that dies of a preventable cancer, so I think a cancer that you could predict with a genetic test is a cancer that we could potentially prevent. To me, that is like on us if we have not found a way to help somebody prevent. So cervical cancer is a cancer that's caused by the human papillomavirus. We have a highly effective vaccine now for that. And we have not changed mortality for that cancer in this country for 20 years. And, you know, the World Health Organization, you know, wants to eliminate cervical cancer globally as a public health problem for women in countries with much lower resources. So in my opinion, if there's a preventable cancer that women are dying of, then we're not like doing our job as a society and as a country to provide adequate health care. So that that's a long answer, but like I think we've made massive strides in understanding risk, and now we have to figure out how to implement like adequate prevention and surveillance.
Absolutely. And thank you for mentioning that because, as you said, if it's a preventable cancer, then we should be, as a community and as a country, and you know, just even globally, take the adequate steps to prevent before the treatment, right? So
Exactly.
yeah.
Any of your overcomers who have gone through treatment would choose prevention over treatment if they had an option.
Absolutely. And you know, I have asked this question before to the doctors that I've talked to, but even with the genetics, right? I feel like we don't know all of the genes that cause these kinds of familial cancers, because we have come across several overcomers that have not tested positive for the genetic mutation. However, they had a mother or a sister or someone in the family, direct link, that got diagnosed with ovarian cancer, let's say 10 years ago. And then 10 years later, that person develops that cancer without a genetic mutation identifiable. So my thought immediately is that there are more genes that we just don't know of, that we still are trying to figure out, I guess. So
one answer is more genes, but another answer is there are what we call cryptic mutations. So cryptic meaning they're hard to identify, that are not picked up by our current technology. And so it may be associated even with the genes we know, but they may be like, for instance, here's your gene in your DNA. And over here, you might have an alteration in the DNA that regulates this gene. And so it's not really a different gene. It's still the gene we know causes ovarian cancer, but it's not a mutation that we're sequencing for because it's at distance from the gene. So yes, I agree. There's still a lot to learn for understanding genetic risk. And then, you know, genetic risk isn't going to explain all the cancers. So everybody, like, I think people are almost more disappointed when they have cancer and they have a negative genetic test, because you would think, oh, it's good, then that means like it's not something I'm going to pass on to my children. But I think it's human nature to want to understand, like, why did I get cancer? Like, and when the test comes back negative, people are like, but then why did I get cancer? Like, it doesn't give you any satisfying kind of answer. So there's still a lot to learn about, you know, what causes cancer in individual people, and that will lead to better prevention in the future. It's not, you know, I can't tell you how many patients I have who say, I exercise every day, I eat really healthy foods. Like, how could this happen to me? You know, we don't have control over all these things, but it's not, we all think that we should be able to influence these outcomes. But we need to understand what's causing the cancers better in order to do that.
Well, yeah, absolutely. So you have been the principal investigator on several PARP inhibitor therapeutic trials, right? And so can you tell us more about this space and how PARP as a treatment is evolving for ovarian cancer and what is expected to come, especially is there any possibility of combination between the two? What is the future forward
All right,
vision?
I missed the last thing you said.
Oh, I was just saying that I wanted to know how is the PARP space evolving? And then I was asking you, with the emergence of the ADCs as another
Okay.
treatment pathway, is
Yeah.
there room for combination between the two? And what does the future forward vision look like?
Yeah, so right now, PARP inhibitors are really being used in the maintenance phase. So people get chemotherapy and then they go on PARP inhibitor after completing their chemotherapy. The reason that evolved over time is that PARP inhibitors are hard to combine with traditional chemotherapy because they both lower blood counts, and when they're put together, you can't get full dosing of either one. And so it became more effective. It just wasn't really feasible to do that combination. So some antibody drug conjugates, it's going to be the same thing that because they do have these little packets of chemotherapy, they can lower blood counts. So they may be hard to combine with PARP inhibitors. Others have maybe less hematologic toxicity, and you could actually combine them outright. But you could also do the same thing. Antibody drug conjugates are going to be used maybe with traditional chemotherapy or on their own, and then you could follow it with a PARP inhibitor in the maintenance phase. So there's a number of different ways you could sort of see combining those two. But whenever we have two effective therapies, we think about, well, how could we put them together and make them, because basically you want to sort of minimize toxicity, but find the most effective combinations. So it's definitely an area of development. The antibody drug conjugates are looking so good in the recurrent setting that there's studies now opening up to get them earlier into the treatment paradigm for ovarian cancer.
Yeah, and thank you for mentioning the toxicity, because that was the question that was playing in my mind when you were talking, that, because with the PARP and the chemo and the ADCs all together, what does the toxicity profile look for patients? Because it sounds like a lot altogether.
Yeah. So I think because of that, we'll probably PARP inhibitors will stay in the maintenance setting. But I mean, we have to be careful as researchers not to forget the patients. That's why the advocates that we work with are so important, because they keep us grounded in what matters to the patients. I mean, ultimately, it's our patients that matter. We're trying to give them better lives. And we can get so caught up in the science that we're like, well, let's combine. I mean, there were some ovarian cancer trials like a few years ago that were proposed with 3 drugs for maintenance therapy. And each one of those drugs had some toxicity. And I guess I would ask, like, is it really maintenance therapy if you're taking 3 different drugs and all of them are toxic? Like, aren't you just basically still on therapy? Like, is it maintenance? I don't know if a patient would feel like it was maintenance if you're going in all the time for blood testing and all this stuff because you're on 3 different, anti-cancer drugs. So it's really like we have to find that balance where we optimize the chance for cure, we prolong remission, we keep the cancer at bay, but we maintain quality of life and minimize toxicity.
That's so taken. Yes. I mean, that was, you are just, speaking my language, because I was going to talk about the quality of life, because that is so important. If you are, if you're handling or managing 3 treatments at the same time, and you're always in and out of the hospital with this test, that test, I mean, the quality of life, and even with the toxicity, right? The quality of life doesn't sound to be too great. So all that balance is so important. Now, ADCs are, as you said, it's a source of hope for treating patients. But now, if there's a specific patient profile, let's say that they are progressing while being on PARP inhibitors, is ADC an option for them? Or and then also this is a question that came from one of our overcomers, that patients that are BRCA negative and HRD proficient, what are some hopeful options emerging for them?
Yeah, so those are great questions. So first, antibody. So one of the things that we're looking at is, I think there's a trial proposed where if patients have been previously treated with platinum and a PARP inhibitor, and there was an interval of a certain amount of time, like a year or more, we would always retreat with platinum again. But there's data kind of, that's emerged that if you've had a PARP inhibitor, your response to platinum may not be as good as in the old days when people didn't have a PARP inhibitor. There's cross resistance between those drugs. So it may be more effective to go to something different, like an antibody drug conjugate. So I think one of the proposed trials is to compare sort of to traditional, go back on a platinum combination chemotherapy versus an antibody drug conjugate and see if that's true. If you've had a PARP inhibitor, you should be skipping that platinum and going to something different. So that's a question that we need to answer. The question that came from someone that was asking, the HR proficient kind of cancer, like the cancer that doesn't have HRD, doesn't have a BRCA mutation, what's in store? Well, I actually think that there's a lot in store for that. But those cancers aren't all the same too. They're heterogeneous. There's different pathways involved. So one group of cancers that's in that group is got amplification of a gene called cyclin E1. And there's drugs being developed specifically for cyclin E1 amplification. And that has been a group of cancers that's been traditionally resistant to platinum chemotherapy. It's resistant to PARP inhibitors. And so I think it gets back to this idea of finding the vulnerability of each cancer type and developing the most effective and not ignoring all the different subsets that are there, because every time we ignore something, we're left behind. So we're leaving somebody behind. And the patients that have been left behind the most in my experience are the patients who don't respond to initial therapy. And in fact, even progress on their initial therapy. Nobody wants them in their clinical trial because the drug companies, it's the more resistant a cancer is to chemotherapy, the harder it is to treat. And they don't want their drug to fail and not be effective. And so those patients are actively excluded from clinical trials. And they're the patients who need clinical trials the most because we don't have effective therapies for them. So this is where we need advocates. Like, it is not okay for pharma and the FDA to have this strategy that excludes patients that absolutely need access to new drugs. These drugs have to be developed, and then we have to give these to the patients. But in the meantime, a whole lot of people have already died. So we have to find ways to include those patients onto clinical trials earlier and to actively develop drugs for people who are not responding to our initial therapy. I feel that one of the problems is those patients aren't living long enough to be advocates for themselves. And also, I feel like their families are so traumatized by having this aggressive disease course that they don't necessarily stick around either. They just want to wash their hands of the experience. And so there's nobody advocating for these patients that have the worst outcomes. And so I feel like we want to make everybody's outcomes better, but we don't want to leave behind the people who are not responding to our initial therapies.
And I will tell you that you hit a personal nerve there because my mom was one of those patients. She never responded to the first line. She did the chemo, the surgery, all of those things, but she did not respond much at all, like maybe few days before her cancer came back. And so, but there was nothing, and this was 10, 12 years ago. And so there was nothing whatsoever available for her after that. We tried what we did for like 11 months before she passed away. So, and as a family, you are absolutely right. We didn't know anything about ovarian cancer, and we were completely traumatized by that experience. So, you understand this, and I absolutely appreciate this. So, thank you. So we have talked a lot about science, Dr. Swisher. So let me ask you, have been doing this and serving our overcomers for the past 32 plus years. What keeps you hopeful and motivated as you care for them each day?
Wow, that makes me feel old. I am hopeful and motivated every day because of the strength and the passion of the patients that I see, and because of the progress that we've made with cancer research. So I know we can continue to make more progress, and I know that's what patients want. And I feel like it's a mission. And not everybody gets to have a job where they feel like they can have that. So I just really feel like honored and like lucky to be able to have a job where I might be able to make an important, contribution in someone's life. And so that's what keeps me coming to work every day. And I'm really grateful for your audience and all the overcomers and ovarian cancer patients that I've seen and patients that I've lost. They keep me motivated too, because I feel like I think back on some patients who I'm like, with the progress that we've made, that if I could treat her now, I would have a much better chance of like curing her or keeping her alive for a long time. And I feel sad that I've lost that patient, but I also am motivated to do better for the next one.
That's a wonderful and beautiful response. Thank you. And so we have talked about a lot of things over the past almost an hour. So what have I missed asking you that you would like to share?
Well, this has been a very thorough. You have pretty much dug out everything that I have hidden up there in my brain. So I think I can't really think of anything like off the top of my head.
Okay, thank you. And I ask this question to every guest. And so what is your message of overcoming that you would like to share with our audience?
I like to tell my patients, plan for the worst, but hope for the best. Always like live life in the present, but we are making advances, and there is always like something around the corner. If you don't like what your doctor is telling you, get a second opinion. It is never like an insult to your physician to get another opinion. If your physician has any kind of issues with that, then they're not a great doctor, because like I would always want my patients, it is a life-threatening illness. And I like it when they go and get another opinion, because maybe I've missed something, and it's never an insult to me. And so, advocate for yourself. There's just quite a heterogeneity of options out there and care that you might receive. So don't ever be embarrassed or feel bad about getting a second opinion.
Thank you so much, Dr. Swisher. And just I would add to this that for all the clinical trials that you're running in your lab, especially the Chances study, if anyone is interested, they can look it up on our website or clinicaltrials.gov website, and then also contact you directly, right?
Perfectly. Yes. Thank you so much. I really appreciate your time today.
Wonderful. Thank you. Thank you, Dr. Swisher. This was an amazing conversation. Like you said, we went through a lot today in the past 55 minutes to an hour. So thank you for your time. And overcomers, hope this was beneficial for you. As Dr. Swisher mentioned, she's running some fantastic trials in her lab, including the Chances study. So look it up. And if you have any questions, please reach out to us or Dr. Swisher for any questions that you may have. And please share this video far and wide with anyone who may benefit from all the pearls of wisdom and the insights that she shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then,